So Ed, 15 years ago, you started writing about the chronic care model, which we're all very familiar with now. Where did the ideas come from?
I think initially it came from my clinical practice, that it was frustrating that well-intentioned, well-trained physicians couldn't get high levels of disease control among its patients with high blood pressure, diabetes, and other common conditions. Started reading to see why that was. There was an evidence base about how practice could be changed to get better outcomes for patients with these diseases. And I think it was that evidence that we thought needed to be communicated to the practice community in a way that they might find useful.
So talk a little bit more about the role of the patient within the chronic care model.
One of the things that became clear that was wrong was that the patient who is making the decisions about the management of their health and illness 99.9% of the time weren't being considered in the equation. Medical care was doing all of the management and assuming that patients would go home and do exactly what medical care told them to do. And then literature began to suggest that the way we were educating patients wasn't working, that didactically telling them what we thought they needed to know wasn't changing behavior, wasn't improving outcomes, and that what did seem to make a difference was actually collaborating with patients, trying to help them and help us understand their point of view. What was their sense of what the problems were? What was their sense of what the solutions to those problems were? And could we bring that together with what the evidence told us they might need to come up with a plan that they might actually find both consistent with their point of view and their values and worth trying.
So the patient is at the heart of this, but in your latest development of the chronic care model, you have the prepared, proactive team working together to support the patient. Say a bit about who should be in that team.
The only way that all of that evidence-based and other service and meeting the needs of patients can take place is if it's shared. And what we're trying to figure out now is who exactly the provider most cost effectively would share that with. Nurses, medical assistants, which is, I'm not sure in the UK whether that term would mean anything, but it's somebody with a limited amount of training who does things like takes blood pressures and so on, but not much more than that.
And what about the role of the GP within that team?
Well, the primary care physician is clearly a member of that team. May not even in the current thinking necessarily be the leader of the team, because they're often not very efficient in their management roles. But clearly, having someone with clinical skill is critical, but it's not enough. And so there needs to be individuals on that team who are effective self-management supporters and counselors. There need to be people on that team who can help patients deal with the coordination issues when they need service outside the practice. There need to be individuals on the team who make sure that patients have their logistical needs met, whether it's transportation or access to appointments, whatever. All of that is what makes for effective primary care. And if the physician has to do it all, obviously it's not going to get done.
So what about patients we talk more and more about these days, patients with multi-morbidity, complex needs? We're not just treating the hypertension or the diabetes, we're treating the person who has several conditions. Is the team model you've described the right one for them?
They're going to need more. They're often going to need help with behavior change. They often need help with just sort of fundamental social needs of transportation, income, housing, and so on. We have to be able to have the capability of changing the configuration of the team depending on the needs of patients, and that obviously is going to require a better connection between primary care practice and the surrounding community and its resources.
So what you're describing in my language is a model of much more integrated care, joined up around people with complex needs, around the populations they serve. Is integrated care the same as good chronic care?
We prefer to use the word coordination as separate from integration, in that integration is a characteristic of the environment. Coordination is actual activity, deliberate activity on the part of caregivers to make certain that they are working together well with each other and protecting the patient from the potential pitfalls of having to get care from multiple places and people.
Jeremy Hunt, our health secretary, has recently said for older people, particularly vulnerable older people, there should be an accountable clinician responsible for coordinating their care, making sure they navigate around often quite a complex system. Do you think that's a good idea?
I think that's absolutely the right idea. And it's the whole basis of the American patient-centered medical home movement, which is that at the heart of care, regardless of how complicated the patient is, needs to be someone who, if not a generalist, has generalist perspectives and is willing to take on the comprehensive needs of the patient to assure that those comprehensive needs are met, not necessarily by them, but by coordinating with the variety of services that will meet the needs of that patient, but also has that what the literature calls whole person knowledge of the patient, which is missing even in well-integrated care when the care is all rendered by essentially strangers to each other and strangers to the patient. So what's missing there, and it could be beautifully coordinated with shared electronic records, but if nobody in that integrated team really knows that person, knows who they are, where they've been, their life circumstances, what their home is like, what their caregiver relationships are like, it becomes, I think, something important is missing.
One of the things that's happened in all countries is increasing specialism in medicine, but with aging populations with multi-morbidity, we're losing something, I think, around the importance of generalism, particularly in relation to the care of older people. I know you've studied this, you've thought about it. The role of medical specialists who specialise in the care of older people, what part do they have to play within the chronic care model or within the integrated systems that you've been an advocate of?
Often what many geriatricians have found is that the care plans for older people are just not appropriate to their age, to their level of physical and cognitive function, and people are getting unnecessary care that is really irrelevant at that end of the age spectrum, and are missing important elements of care, often of a psychosocial sort. So getting the care plan not only clinically correct, but correct for the age and level of frailty and social and emotional situation is also a challenge. And I think that's where geriatricians have their expertise.
So geriatricians in your country are a very rare breed. We have far more in this country, which ought to give us an advantage. You know a bit about England and the national health system. How well placed do you think we are to deal with this ageing population, the challenge of multimorbidity, and the role of geriatricians specifically within that?
I think you're very well placed. I mean, not just because you have a much higher population ratio of geriatricians than the U.S. does, but also because of what I know about geriatric training in the UK. And there's much more generalist orientation. I think you could be an international model for how we integrate geriatric expertise into the daily routine care, which has to be through primary care of older people.
How well placed do you think England is going forward to really build on some of the strengths we've talked about?
Well, the great strengths in the UK are the solid foundation of primary care, and not just because primary care is ubiquitous. It's because it's always been a policy priority here. I think your challenge in the UK has been the geographic separation of primary care and specialty care. And as you go forth in integration, closing that gap between the surgery in the community and the hospital and the specialist, closing that gap is the challenge.
So when we talk about integration, can I just be clear on this? The benefits really accrue from clinicians working more closely together, from services coming together. It's not about massive organizational change.
No, exactly right. I mean, if it isn't happening at the individual patient level, happening at the agency level is irrelevant. So it's got to happen at the individual level, and that means that provider behaviors are going to have to change.
Ed, thank you very much indeed.
It's always a pleasure.